Good afternoon. We're back, and I hope everybody had a chance to have a nice lunch or attend to some clinical issues from since this morning. I'm happy to start our afternoon session, and I'm here with Dr. Alex Gamble, who is going to present on late life depression. So, a topic of interest, I think, both to geriatrics and to palliative care. Dr. Alex Gamble completed his medical education at St. Louis University, followed by a combined internal medicine and psychiatry residency at the University of Iowa Hospitals and Clinics. And then he went on to complete a fellowship in hospice and palliative medicine at the University of Kansas. After working for several years in rural Missouri, he developing a palliative care program at a regional hospital. He worked two more with the inpatient pal care team at North Kansas City Hospital and as faculty for the HPM fellowship at KU. And then he went on to join the palliative care section at Stanford. In addition to working as part of both the inpatient pal care consult service as well as the outpatient pal care clinic, he's the site director for the inpatient palliative care rotation at Stanford and continues to pursue his interests in program development, education, and the integration of psychiatric and psychotherapeutic tools and concepts into the practice of palliative medicine. Thank you so much for joining us, Dr. Gamble.
Thank you, Sonika, for the opportunity. And thank you all for sharing this time with me this afternoon. I'm hopeful to provide some good tips, pointers, and review for preparation around late life depression. So our time together is limited, but hopefully it'll be very fruitful for you. And we'll go ahead and hop right in. So I have no relevant financial disclosures. I work for Stanford. Nobody else pays my bills. Our objectives today are to look at the depressive symptomatology as along a spectrum from normal experience to mental disorders as described in DSM-5, and we'll talk a little bit more about what I mean there. We'll talk about treatment approaches for depression in older adults and those with serious illness specifically. We'll formulate individualized treatment plans, including pharmacologic and non-pharmacologic modalities, and we'll think about our current approaches to communication with patients around depression, including diagnosis and treatment planning. And this consideration will be kind of peppered throughout our discussion today. So the first place I want to start is kind of reevaluating our framework. I think what I find when I speak with a lot of my colleagues is that there's often a kind of fear or tension around making a diagnosis of depression, this sort of sensation that the DSM is kind of this very strict rule book and that we have to have perfect mastery of the diagnostic criteria, and that if patients don't fit those criteria perfectly, that we can't use that diagnosis. The quote I have here is from the DSM itself on the use of the manual. And what it points out is that the DSM is really meant to collect information around these kind of clusters of diagnoses, but it's not meant to be exhaustive, that each patient's presentation, their circumstances are going to be infinitely more complex than can be captured in this sort of simple book. And so the book is really meant to be used as a guide for us. I think in particular, for those of us whose practice hasn't necessarily had, thousands of repetitions of seeing a wide variety of presentations that sort of fit within this category of depression, it can sometimes be difficult to think about what should we be looking for. And so I think we can start by thinking about the criteria in the DSM as a guide for us. What types of clusters of symptoms do patients typically have? And then, of course, the way that we've studied our treatment modalities is organized around those diagnoses. So that's also to give us a better sense of how likely are they to benefit from a specific treatment, given what's been shown for that treatment in the past. And so the first thing I wanted to invite us to is to kind of step back and think about our relationship with the DSM. It's really meant as a guide for us to have a sense of what types of experiences our patients might be having, think about how to categorize them, and then how we might go about trying to meet them in their suffering and their difficulties and formulate a treatment plan. So the DSM-5 really tried to focus around this conception of mental states as a spectrum, going from adaptive to maladaptive to pathological. And so there's not necessarily the clearest threshold for what counts as pathology because we really step back and think about the fact that this is context contingent, right? What's adaptive or maladaptive really depends on the circumstance someone's in. It's subjective. It depends on how the individual is looking at it. It depends on the situation. And there's also cultural considerations that are involved. The other thing that I think it's important for us to think about is that the level of subjectivity, there are not objective tests for these diagnoses. We don't have blood or imaging tests that we can rely on. And so we're also meeting patients where they are in their capacity to recognize and name and describe what's going on with them. And so I think there's a lot of need for us to have language to meet our patients where they are, to try to help them find ways to describe what they're experiencing. And then importantly, think about how it's impacting their life and their situation. What was adaptive in a prior situation may now be maladaptive. And the struggle might really be in figuring out how to navigate a new situation that feels unfamiliar to them. So let's hone in on our population. We're talking today about depression in older adults. And in general, we note that it decreases with age. For general patients living in the community, the prevalence of depression is somewhere between 1 and 5%. But if we think about our patients that we're seeing more often in the hospital or perhaps seeing more frequently in the clinic because they have an increasing burden of illness, what we observe is that in hospitalized patients, the rate is 11.5%, in home health care, 13.5%, chronic health problems or folks who are living in long-term care facilities as high as 25%. And this is patients who meet criteria for depression. If we're just looking at clinically significant depressive symptoms, so below the threshold for a formal diagnosis, but demonstrating these symptoms, it's anywhere from 10 to 50%. And so what I'd say is we note here that it's actually quite prevalent depending on the subset of patients that we're thinking about. And for many of us, it's a lot of the patients that we're seeing. And so the case here, I think, is to be made that this is actually quite prevalent in many of the patient populations that we're caring for. And so it's worth looking for. When we think about who's at risk for depression, we've got a number of risk factors here that are well described. And I think, again, when we think about patients that are accessing medical services more often, folks who are having stressful life events, or our patients as they're advancing in age, they're confronted with more losses, breakdowns in relationships, death and bereavement, sleep disturbance. We know that in general, as we age, our sleep declines and is of lower quality, setting aside even the question of comorbidities that might contribute to that. Medical illness, and the more illnesses that they have, the more likely they are to develop depression, more medication side effects as we increase the number of medications that folks have. And so in particular, again, I think when we think about our patients who are high utilizers of the system because they have a greater number of comorbidities or have more advancing illness, we see that they're certainly at higher risk. And so again, I think the case here is for universal screening and looking for depressive symptomatology among our patients, particularly as their level of medical complexity is increasing and they're developing additional problems. And then why does it matter? Why should we be looking at it? Because it's common. Why should we care about it? Because it has huge impacts for our patients' quality of life. It can reduce their ability to find meaning and purpose, impair their sense of quality of life, shorten survival in some illnesses, can worsen physical symptoms such as pain. Certainly for patients that are presenting with pain complaints, it's worth thinking about how is their mood, how is their anxiety, how is their sleep, because these things are certainly deeply tied together. Our inability to recognize problems with mood is going to curtail our ability to really manage their pain effectively. Has broad impacts on life, interfering with relationships, causes distress in their broader unit among family and friends, can interfere with treatment adherence, and is a significant risk factor in suicide and requests for hastened death. And so again, what we see are very significant impacts that I think highlight the importance of this question and looking for it. So let's jump over to the DSM-5. It's always, as I said, good to be familiar. Again, I don't think we need to be worried about, do patients meet these exactly strict criteria with respect to considering whether or not this is having impact on their life. So it requires 5 or more of the following nearly every day over the same 2-week period and leading to a significant impairment in functioning. So what we see here is, like pretty much all the diagnostic definitions in the DSM, there's a time component, recognizing that sadness, even prolonged sadness, a few days, is not uncommon in our population. And this significant impairment in functioning. As we described before, there's some subjectivity there, and it depends on the circumstances that someone's in. But these are really the markers that we're looking for. So the time period, the impairment in functioning, and then these different factors. So one of the 5 that we're sort of looking for to fit this precise definition needs to be either depressed mood or a loss of interest in pleasure, marked anhedonia. And then the rest can be from among this larger group, feelings of worthlessness or inappropriate guilt. I single this factor out because this tends to be for our patients with more advanced stage or more illness, one of the clearer markers of depression. When we consider the rest of these factors, we recognize that these can often be reflective of an advanced illness state. And so it can be harder to really distinguish, are these other symptoms, changes in appetite, changes in sleep, psychomotor slowing or agitation, fatigue or loss of energy, diminished ability to concentrate, can certainly all be reflective of medical illnesses, which can lead to a bit of diagnostic difficulty. Some authors have recommended really focusing more on the mood, the pleasure, and then those feelings of worthlessness or guilt as clearer markers of a depressive state as opposed to secondary to a medical illness. Recurrent thoughts of death and suicidal ideation, and always an important one for us to think about. We recognize that for risk of suicide, there's kind of a bimodal curve where much younger patients and much older patients are at higher risk. And so again, when we're thinking about our older population of patients, we want to be really mindful about this factor as well. We'll talk more about that in a moment. We need to also rule out that there's been a manic episode or hypomanic episode. So we want to ask about periods of sort of the inverse of this, right? Decreased need for sleep, increased activity, the normal things we're looking for in mania. And then this is, I think, one of the tricky ones for us in our older patients and folks with more comorbidities, that symptoms are not the direct result of a substance or general medical condition. What we find is that even if there does seem to be significant overlap, there's still value in sort of treating. What we want to be thoughtful about is in counseling our patients, what are our expectations for recovery if we think a lot of their symptom burden may be driven by, for example, their advanced heart failure, their cancer. And bereavement, lastly, this last note, bereavement does not exclude the diagnosis of a major depressive episode. So just because somebody is experiencing a loss and are in their period of bereavement doesn't mean they can't also have major depression on top. And so again, while these are the criteria for major depression, we also recognize that folks that don't meet this threshold, that perhaps it's not hit that 2-week mark, perhaps it's not having overt signs of impairments in functioning, they may still be having these symptoms. It may be causing a lot of distress, and it's worth paying attention to. As we mentioned, there are particular challenges in making these diagnoses in patients who are medically ill. So depression and medical conditions are closely linked. What we see is that the worse someone's depression is, their medical illnesses tend to do worse, and vice versa. It can also, as we mentioned, be hard to separate from severe illness. And so, as we mentioned earlier, it's helpful to focus on those non-neurovegetative symptoms, the dysphoria, the lack of pleasure, those feelings of worthlessness, hopelessness, helplessness, guilt, and despair. We touched on suicide briefly. A couple of important statistics. Women are more likely to attempt, but men are more likely to succeed. This principally reflects that the more lethal means that men typically select, often more with firearms. We always want to assess for suicidality in patients with depressive symptoms. Talking about it decreases risk. This is a common misconception people have, that, oh, if I bring this up with a patient, I'm going to increase the risk. It actually decreases it. And we find among important red flags, folks who are isolated, who are describing a specific plan, and certainly if they're also talking about practicing or kind of taking steps along the path of that plan, folks that have a history of serious attempts or who know someone who've completed suicide. In patients who are expressing some, we want to complete a risk assessment, looking at their intent, whether they have a plan, whether they have access to lethal means. There are good tools out there. If they're not utilized in your current clinical environment, you might think about something like the Columbia Suicide Severity Rating Scale, which is in wide use throughout the VA systems and been adapted in other places. They have fabulous resources online that are totally free that can help even look at how to integrate this into your clinical site. And if the immediate risk is felt high for a patient, this is someone who has an active plan, who has intent, we don't want to leave them alone. We want to get psychiatry involved. Depending on our setting, we might need to think about what's that going to look like if we're in clinic, if we're on telemedicine. How are we going to stay connected to this patient? Do we have clear ideas about where they are? Important considerations that we won't get into too much depth today because we've got other ground to cover. We also want to be thoughtful about cultural considerations. As we mentioned, DSM is a guide. It's not an exhaustive rule book. Depression can look differently across different cultures. I mean that here, both geographically and sort of endemically. Depression in some cultures carries connotations of a loss or lack of personal strength or fortitude. So for patients to acknowledge sort of this ongoing sadness can be something that's taboo for them. they may present with other dominant symptoms like physical symptoms. So if I was told from a young age that I'm not allowed to cry, but I get consistently attention for having physical pain, then perhaps my mood is actually going to show up more with chest or belly pain, right? So we want to be thoughtful about what is the context that our patients are coming from. Again, what are the idioms of suffering in the background that they're inside of? Um, it's really important for us to meet our patients where they are. So being thoughtful about what is their experience, how did they come up, asking overt questions about, how did you talk about emotions, or were emotions sort of encouraged, or where did you go for assistance and support? How are you accessing that now? Really trying to understand deeply what are the specific circumstances our patients in, how do they think and talk about these things? Often our patients come with significant deficits in language or speaking a different language in terms of talking about their emotionality than perhaps the dominant paradigm that we're accustomed to. So really being thoughtful, not just about what are they overtly expressing, but how else might things be showing up for our patients? So in thinking about other modalities that have similar presentations, I wanted to run through a few really important ones, particularly for our older patients. One is demoralization, which is not currently featured in the DSM, but has increasing clinical interest. And I think in future editions, we may see this formalized, again, recognizing that it has significant clinical implications, pardon me, specifically with regard to requests for a wish for hastened death, or patients who are interested in accessing medical aid in dying. Demoralization is conceived as the experience of emotional distress, such as hopelessness and having meaning and purpose in life lost. It's characterized by attitudes of helplessness, failure, pessimism, and a lack of a worthwhile future. What we observe is that these patients have a reduced coping to respond differently. So they're having difficulty finding different ways to respond to their circumstances, this sort of feeling of disconnection and a lack of a sense of a worthwhile future. Often we find that they're socially isolated or deficient in social support, and that we see the persistence above of those features for greater than 2 weeks. And lastly, that features of major depression have not superseded as the primary disorder. So really trying to differentiate between folks that are principally feeling disconnected from kind of the flow of their life, seeing the impact that that's having, has a lot of similarities to depression, but there's increasing evidence that this seems to be a distinct entity and responds to different treatments. So again, can we target this isolation? Can we get them reconnected? Are there other resources that maybe they're separated from, or are we able to connect them with additional resources? Do we have social work or psychology resources we might be able to connect these patients to? For our patients in advancing life, as we mentioned earlier, they're often confronted with increasing losses, loss of a sense of identity, loss of relationships through death or separation. And so a lot of our patients are experiencing grief. And so wanted to just offer a quick resource for considering normal grief versus prolonged grief disorder. So in normal grief, we see recurrent feelings of yearning for the deceased. Intermittent pangs of deep sadness, a steady stream of thoughts are often thinking about this person that they've lost. They may struggle to accept that reality, but that's the process that they're working through. So again, there may be difficulty, but we see that there's progression over time. There may be somatic distress like frequent sighing, a loss of appetite, or sleep disturbance, and they may feel disconnected. Again, what we see are kind of these increasing patterns of sadness that are oriented around the individual, but what we're not seeing are significant disruptions to kind of their daily life and activity. Whereas with prolonged grief disorder, we see this sense of identity disruption. That is, the person feels like they've lost their sense of self, intense emotional pain related to that death, avoidance of reminders that the person is dead, a marked sense of disbelief. So what we're really recognizing in this prolonged grief is this sort of sense of rupture, right? That people are sort of drawn out of their continuity of working out, how do I make sense of my life without this person, right? That it's so painful, it's so disruptive that they're at a certain point withdrawing. Lastly, there is this time component that we were saying there's at least 12 months since the death, and they have 3 symptoms nearly every day for the prior month. So again, for meeting the strict formal criteria, there are these time intensity components and how complex it is, but we recognize that we may have patients that are sort of sub-threshold for diagnosis, but who are suffering enormously. And so again, we still want to be involved and engaged with our patients when they're disclosing significant losses. What is the impact? How are they experiencing this? And are we seeing signs that they're having difficulty that they might warrant additional treatment or escalation, or even just more counseling and discussion in our visits to sort of help them think about how are they progressing or not, or where are they stuck? How is this impacting their quality of life? We look at risk factors for prolonged grief disorder, death of a child, death of a spouse, comorbid PTSD, a violent or unexpected death of a loved one, patients with older age and economic stressors, or folks with increased dependency on the deceased prior to death. Again, when we think about prolonged grief disorder as being this sort of sense of rupture, again, I think these risk factors make a lot of sense. These are really significant relationships that are often deeply tied to a patient's sense of sort of the future. Having these kinds of sudden, unexpected, major, and seemingly catastrophic losses are put patients at greater risk for this more impactful, more intense, more disruptive process of bereavement, and put them at greater risk. So we want to be thoughtful about how our folks, our patients who are experiencing these types of losses, how are they coping, how are they progressing over time, and think about whether they need additional resources or support. As always, we want to be thoughtful about cultural considerations, especially around grief. Each culture has its own rituals and customs that influence the way that their grief is expressed. Each culture has its own beliefs about the meaning and purpose of life and what happens after death. So we want to really explore with each of our patients what's normal within their own culture, right? And we think about that at every level. So within their familial culture, within their broader community, right? Many patients may come from one culture that may be their culture of origin, but they may not feel embraced by that culture. And so also having a sense of sensitivity around whether they identify with the culture and how they sort of interact within that space. All keys to really understanding what they're going through and whether this may represent kind of a normative process for them or something that's more disruptive that we might be able to target for support to improve, again, their sense of well-being as they're sort of traversing this landscape of grief and loss. So another diagnosis that crosses the threshold of mood issues or can cross the threshold of mood disturbance is adjustment disorder, which is defined as an emotional or behavioral symptom in response to an identifiable stressor within 3 months, marked by one or both of marked distress out of proportion to severity of the stressor, significant impairment in social, occupational, or other important areas of functioning that does not meet criteria of other mental disorders, cannot be bereavement, and once the stressor is over, symptoms last less than 6 months. We can specify whether that's with depressed mood, anxiety, disturbance of conduct, or mixed depressed mood, anxiety, or disturbance of conduct. And so here we may be seeing a patient who has, again, some significant stressor that in response, they're having depression or lower mood that's out of proportion. I think the big question with this diagnosis is what counts as out of proportion. And again, I think this really reflects the subjective nature of these disorders, of the difficulties that our patients are having, and really requires that we're thoughtful and sensitive to the circumstances of each of our patients in understanding what is the nature of their experience and how much distress is this causing. Which brings us to the question of who warrants treatment, right? So if we're thinking about what is the impact, what is the subjective and objective experience of our patient, how is it impacting them? The DSM itself says the fact that some individuals don't show all the symptoms indicative of a formal diagnosis should not be used to justify limiting their access to appropriate care, right? So again, these diagnostic criteria are there for us to have clarity about diagnostic paradigms, principally so that we can have defined populations for study. We can look and see, okay, who is the group of people we're going to try this intervention with, this medication, this therapy, to see whether they're going to gain benefit. But when we step back and look into the broader population, what we recognize is there's a lot of suffering and a lot of distress out there that doesn't necessarily fit neatly into these formal criteria. And so when we're making decisions about who actually warrants treatment, we want to be thoughtful about each patient's circumstance. What is the suffering that they're experiencing? What is the difficulty that they're having? And then be thoughtful about how we can put together a treatment plan for them. One tool that can be helpful in trying to decide what is the impact are looking at depression screening measures. Some of the most common ones used in clinical practice that we should be familiar with for board preparation purposes certainly are the Patient Health Questionnaire 2 and 9, which is abbreviated as the PHQ 2 and 9. The 2 is a simple 2-item question asking about over the prior 2 weeks, how often did a patient have difficulty with little interest or pleasure in doing things, feeling down, depressed, or hopeless. So that's those two core elements, right? Depressed mood and anhedonia, lack of pleasure. The 9 goes into the rest of the criteria that fit within the DSM criteria for depression. And the ninth question itself is specific to suicide risk. So in some settings, they'll use as just a screening tool the PHQ-2 plus the ninth question to try to identify patients who are at greater risk for suicidality or experiencing suicidal ideation. The PHQ-9 can be used not only as a screen, but also to measure severity. And this can be helpful over time, as if we do embark on a treatment course with a patient to target their depressive symptoms, folks often adjust really quickly. And so even if they're seeing benefit of their medication, they may normalize, sort of find their new normal, or it may be difficult for them to discern how much benefit got from this treatment. And so it's worth thinking about not only using these tools for screening, but also for patients who screen positive or who were concerned or embarking on a treatment plan for their mood to try to determine, hey, are we seeing benefit over time? Are we seeing decreases in their symptoms as time goes on? This is what the PHQ-9 looks like in detail. And then another common scale, particularly thinking about patients with advanced stage, is the geriatric depression scale, or the GDS-15, has a cutoff of 5, focused on symptoms over the past week, and is in a simple yes/no format. So a little bit easier to work with than the PHQ that has a Likert scale that can give us a finer sense of sort of severity. So when we're thinking about treatment, the first step is we want to really aggressively treat other physical symptoms. So if they're having issues with pain, if they're having issues with sleep, are we targeting those other symptoms that might be contributing and addressing those as aggressively as we can? We may consider psychotherapy. There's an evidence for a variety of modalities, and we'll kind of look at a few of the more common ones. Psychotherapy is well tolerated, doesn't have side effects the way that other medications can, which we'll talk about as well in some detail. We want to encourage exercise and movement. Just getting our patients up and moving again has been shown to have benefit, what's often referred to in the literature as behavioral activation. So getting them up, getting them moving, getting them back in connection. We also may think about antidepressants. Importantly, again, for our patients with advanced stage or with serious illness, we want to be thoughtful about prognostication. We want to think about identifying patients for antidepressants, whether or not they have a life expectancy of greater than 2 months, recognizing that getting them to an adequate level can take weeks, if not months, to get them to an appropriate threshold with psychopharmacologic treatment. And then where time is shorter, we might think about psychostimulants, so we want to be judicious as well. When we think about therapy for depression, there's evidence for a variety of modalities, including, as I mentioned, behavioral activation, cognitive therapies, cognitive behavioral therapies, interpersonal therapies, and problem-solving therapies. This is not an exhaustive list. What we find is very often the more relevant question is going to be, what therapy do my patients have access to? So here we're thinking about, am I in an urban, suburban, or rural setting? One of the benefits coming out of the pandemic has been increased access to telehealth and telemedicine, which has certainly increased access for a lot of patients who maybe would not have had access to a therapist in the past. Very often what we find are patients may be resistant to the notion of therapy. And in that case, I think what we might point out is the level of connection, the therapeutic alliance that they've built inside of our relationship with them. And so being able to just call attention to the fact of whether they seem to feel better or seem to have some relief in talking with us about their problems, pointing out that there may be value in digging into that more deeply with somebody who has additional professional training to address those questions with them. And so ultimately, the modality, what the literature shows us very clearly is even more than specific modality, it's the therapeutic alliance that makes a difference when it comes to the impact of therapy for patients. And so leveraging our own relationship with them can be a valuable first step in getting them connected to a provider that they feel comfortable to explore their questions and difficulties with. Again, we always want to keep cultural considerations in mind. The most important aspect of therapy is that connection. And ultimately, patients don't fail treatment. It's often a matter that we fail to understand and meet their needs. We want to really be thoughtful about what is it that they're struggling with and how do we meet them in that struggle. As an example of how we can integrate therapy even into our busy clinical practices, we've got the BATHE procedure, which is a simple acronym. It's not a good medical talk without a fancy acronym. BATHE stands for background, so what's going on in their life. Affect, how do they feel about it. Trouble, what troubles you the most about this. Handling, how are you handling that. And empathy, that must be very difficult for you. So very simple procedure that allows us to delve into the difficulty of our patient, highlight how they're working their way through it so we can highlight their strength and their efficacy, or identify places where we might be able to join with them in that work or connect them to resources to support them, while also empathizing with them, acknowledging the difficulty that they're having, which in and of itself can strengthen our therapeutic alliance, can build that connection, which then can be built upon by another provider in a therapeutic modality. So again, recognizing that often patients are reluctant for a variety of reasons to pursue therapy, we can see that our connection and relationship with our patients itself is therapeutic, and can often leverage that as an example of the types of connections that are available to them in the pursuit of work that can help address things that they might really be suffering and struggling with. So when we've thought about, discussed therapy, maybe you're engaging them with them, but they're still having a lot of difficulty. How do I select an antidepressant? Well, there's a few different considerations that are relevant and helpful in selecting among the variety of antidepressants that are available to our patients. The first is to think about what are their most distressing symptoms. For patients who are struggling more with anxiety, agitation, aggression, irritability, or suicidality, the evidence points to SSRIs. In general, these are considered as our first line of treatment because they both show our best efficacy, though it's certainly nowhere near 100%, and they're considered as the most tolerable. They have the least side effect profile, though there is some variability among the SSRIs that we'll highlight in a moment. For folks who are struggling more with anhedonia, apathy, low energy, or low motivation, we may consider starting with an SNRI if there aren't other contraindications. The noradrenergic effects of the SNRIs tend to give a little bit more of that energy lift and that boost. Conversely, for our patients with anxiety or agitation, that may give them more difficulty. And so again, in those cases, we'll focus more on SSRIs compared to SNRI. We want to be thoughtful about the potential side effects of these medications. So do we have concerns about mania and activation? Do we have concerns about the anticholinergic effects of a medicine? Are we concerned, is our patient already having issues with sedation or on other medications that may be sedating? Are there specific dietary requirements? Are they at seizure risk? Again, all or any of these can be considerations for a variety of medications. And then lastly, what concerns do our patients have about taking the medication? And that's a crucial one because, again, thinking sort of culturally, when we look at the data, anywhere from 10 to 75% of patients are non-compliant with their medications. And this is especially true for psychopharmacologic meds. The rates are higher in intercultural settings because of cultural differences and expectations for treatment, and often inadequate communication. So again, really the focus is on, have we queried, have we asked our patients about their reluctance, their hesitance, or their concern about these medications, and have we adequately counseled through that? It's ultimately going to make a big difference as to whether or not they're taking these medications. None of them work with a single dose. They have to be taken consistently. Often we have to titrate up to an appropriate dose, but do our patients understand that? And have we adequately addressed any concern or reservation they have about taking those medications? They're often concerned about how it's going to affect them. And so again, have we spent an adequate amount of time in our session, in our clinical setting with them, really exploring and addressing those concerns to try to help them get more comfortable with this plan of taking a medication every day. For patients with advanced stage, we really have to be thoughtful as well about the pharmacokinetics and pharmacodynamics, recognizing that as we age, there's a number of changes that are going to impact how these medications affect us, are processed, and it's going to have implications for how we start and titrate these medications and what doses we're looking for. So in general, we recognize a decrease in lean muscle mass, decreased total body water, increased total body fat, decreased renal function, decreased hepatic function, all of which are going to create a circumstance of increased concentration and less clearance. That is, the same medication we might use in a younger patient is going to concentrate more readily and is going to clear from our patient's systems, which increases the potential for side effects. And so we need to be thoughtful both about how we start and manage these medications over time. So in general, we want to start low at the lowest potential dose. In my practice, among the SSRIs, for patients who have a history of being very sensitive to medications, or where that's a great concern for them, I will often start them with sertraline because just among these medications, it comes in a dosing that allows me for the smallest increment of dose. That is, sertraline comes in its smallest tablet at a 25 milligram, which can be split in half, and so patients can be started at 12.5 milligrams. For any SSRI, for any of the antidepressants we're selecting, what we do want to do is always start at the lowest dose. And then we tend to titrate them very slowly. So typically looking at increasing our doses in 1 to 2 week increments, as long as our patients are tolerating them well. In younger patients, we may move much more aggressively to try to get to that target dose. And our older patients, again, recognizing the changes in physiologic function and clearance, we often need to go much slower to try to ensure a smooth up titration process, that they're tolerating it and minimizing the likelihood of side effects. In general, we're going to expect it's going to take somewhere between 4 to 6 weeks to see a full clinical response. And that's at any specific dose. So if we're started sertraline, we started at 25, went to 50, we're often targeting doses of 100, 150 milligrams. And so again, it may take us, if we're increasing the dose 1 to 2 weeks at a time, several months to get to that target dose. And then recognizing that we've got to be there for a period of time before we're going to be able to make an assessment of whether or not it works. If they're not responding, our first step is to make sure they're actually taking the medication. As we mentioned, adherence to the medical plan is often the first challenge. So we want to be thoughtful about, have we really understood what they're concerned about? Have we addressed that thoroughly? Are they bought into this plan if this is the one that we're recommending and think is most likely to be beneficial for them? If they are taking it, then we want to step that dose up. We may consider augmentation strategies, in particular if they've seen a partial response, but maybe it's plateauing as the dose has been increasing, versus changing to another antidepressant. And in that case, if they're having obviously an intolerable side effect, or if we don't feel like they've seen any significant benefit, then we may think more about changing to an alternate agent rather than augmenting with an additional. So among the SSRIs, their action is to inhibit the presynaptic serotonin pump, so that there's process less, there's more that's available at the synapse. Common side effects with SSRIs include weight gain, sexual dysfunction, increased bleeding risk through activity on platelet function, decreased bone mineral density, which over time can increase a fracture risk, as well as contribute to hyponatremia. So for any of our patients where these are already concerns, we might be thoughtful about monitoring them more closely as we're initiating these medications, to make sure that they're not developing worse difficulties that may land them in hospital or give it some other crisis. Again, SSRIs are considered the gold standard as safest, but safe is always a relative term. No medication is safe. All of them have the potential for side effects. A couple specific consideration among these medications: fluoxetine has the longest half-life. So if we have patients who have difficulty with adherence or remembering it every day, this is going to stay in their system longer, so it's going to be smoother. They're less likely to have acute withdrawal. Sertraline does have an increased risk of GI distress. Citalopram has the least drug-drug interactions, but doses above 40 milligrams, there are significant concerns about QT prolongation, and so that medication has sort of fallen out of favor over time. And escitalopram is an enantiomer of citalopram, so potentially has less side effects. The SNRIs block serotonin and norepinephrine, and so also have the potential among their side effects to increase anxiety or agitation and blood pressure. So we want to be thoughtful about our patients with hypertension. They're also more likely to have withdrawal syndromes. Often patients will describe serotonin shocks. They'll say an electric-like shock or flu-like symptoms. Medications, and particularly venlafaxine, can assist with hot flashes, and can also be helpful for neuropathic pain. Desvenlafaxine is a metabolite of venlafaxine. So if patients have had some benefit with venlafaxine, but not total, maybe worth trying to transition to a similar. Duloxetine also has indications for fibromyalgia. There's also some additional agents with unique mechanisms of action. Probably one of the more common used in our patients with advanced stage is mirtazapine, which moderates both serotonin and norepinephrine. Can increase appetite as well as sedation. And so we'll often take advantage of these factors for patients who are having difficulty with sleep or have low appetite. There's not been any studies showing significant weight gain. So while patients may describe a subjective improvement in their appetite, it doesn't necessarily move the needle for patients where we're really concerned about their weight overall, but can, again, give some relief to just that sense of distress that people have when they're not eating as much as they're expecting. And one thing that's unique about mirtazapine is that we are often going to see specifically those benefits with respect to sleep at earlier dosing. There's also some literature suggesting that for patients who are going to respond in terms of mood and anxiety, that they may see some benefit within days as opposed to weeks. Bupropion moderates both norepinephrine and dopamine, but importantly, can lower the seizure threshold. So for any patients where we're concerned about seizure risk, this is one that we want to either avoid or use really with caution. Tends to be more activating. So for patients with low energy, in particular, there's good data for patients with advanced cancer and fatigue, where bupropion can be helpful. It also tends to have less sexual side effects. And so for patients where that's a prominent factor with the trial of SSRI, this can be a good option for us to rotate to as well, or use for augmentation where appropriate. Buspirone is an interesting medication that's generally well tolerated, but often patients will kind of question its effectiveness. We'll use it more for anxiety, but can be used for mood and can also be used to treat the bruxism from SSRIs and SNRIs. It's not addictive. And so again, when we think about our options for treating patients with anxiety, where we're often wanting to avoid benzodiazepines because of that risk for addiction, tolerance, and dependence, buspirone can be a good option for us, but does require 2 to 3 day dosing, which can be challenging for patients. So this chart just highlights various dosing ranges and the side effect profiles among these medications that we've been discussing. What I'll point out here is that paroxetine, brand name Paxil, tends to have a lot more potential side effects, also higher likelihood of withdrawal and a worse withdrawal syndrome. And so again, among them, we'll see that typically our first lines are going to be escitalopram, sertraline, or fluoxetine in most cases. Among the SNRIs, we talked about duloxetine and venlafaxine. Again, this chart is for reference in terms of like dose ranges. We'll just, again, start at the lower dose with plan for a slow increase in titration over time. And then some of those other medications that we mentioned. One I didn't talk about specifically is trazodone, which is a tetracyclic antidepressant. It's often used off-label at lower doses for promoting sleep. In our older patients, we have to be really thoughtful about the potential for orthostatic hypotension. Again, falls are a big concern in our patient population, so may not be a great choice for us, though among a number of bad options when we think about Z drugs or benzodiazepines may be preferable. Nowadays, we have more options with orexin inhibitors. So if we're concerned about sleep, we do have additional options, but trazodone is one we may also keep in mind, again, for appropriate patients where we're not concerned about those additional risks. When we think about other treatments, so we've talked about augmentation strategies, or patients whose prognosis is less than 2 months, we'll often think about using stimulants, medicines like methylphenidate, which will usually start at 5 milligrams in the morning and at noon, can double that dose if there's not effect in a couple of days and stop if there's not improvement in a week, can go as high as doses of 60 milligrams. Want to be thoughtful about the potential for agitation and anxiety. So our patients who are having a lot of anxiousness, stimulants may not be as ready to go to for us. Again, we want to think about our patients in their context. Probably the most common augmenting agents for depression or patients who aren't responding to our initial trials of antidepressants like SSRIs or antipsychotics. Typically, we're thinking about low doses of atypicals like aripiprazole. Tends not to be sedating. We don't have as much concern about QT prolongation as we do with typical antipsychotics, but we do still need to be on the lookout for tardive dyskinesia, extrapyramidal symptoms, and impulsivity. The other one that's probably most commonly used is olanzapine, typically starting at low doses just at bedtime. Tends to be sedating. So if we're having patients who are having trouble with insomnia and sleep disruption in the setting of their depression, this can be a good choice for augmentation and target that symptom specifically. Folks are often asking about ketamine and psilocybin. There are some indications for S-ketamine for treatment refractory depression, but these are not considered as sort of first line, even in our populations. And right now, psilocybin is still in sort of an experimental for study use only setting and has not reached the point of becoming the standard of care. So we've covered a lot of ground. I hope there's been a lot that'll be useful to your clinical practice and certainly for your board preparation. To review, the diagnosis of depressive disorders, like any other mental disorder, requires clinical judgment. DSM is meant to be a guide for us to think about what are our patients experiencing and to help us have language, frankly, to explore what they might be going through to understand where are they suffering and having difficulty. It's not meant as a strict rule book in our clinical settings. How we communicate with our patients affects how we're received. So we want to be open about exploring these questions, highlight the importance of considering these really impactful disorders and difficulties that our patients are dealing with, and recognize that our therapeutic alliance with them is the foundation. The comfort and safety our patients feel in talking with us can be a bridge to opening that conversation with their loved ones, with the people that support them, or with other medical providers when we're recommending, getting connected for therapy. Ultimately, treatment planning requires shared decision making. Just because we think this patient would be an excellent candidate for therapy doesn't mean that they're ready to go to therapy. And so we really want to think about what is it that they're struggling with? How do we meet them in that struggle? How do we help them understand and see the difficulty they themselves are having and understand the benefits that engaging in a treatment plan that we put together with them might have for them and their quality of life? We want to be really thoughtful about the potential for risks against the potential for benefits and the side effects and make sure we're having clear and open discussions with our patients. With that, I'll conclude my remarks, and I think we have a little bit of time for questions, which I'd be happy to field. But thank you all so much for your time, and thanks for the opportunity to support your clinical work.
Thanks, Dr. Gamble, for a great talk. As you mentioned, there's a high prevalence of depression in the different populations that we're seeing. One question that came up was, what are the best strategies, would you say, to cross taper medications if you end up having to change to a different antidepressant?
Yeah, that's a great question. I think it's going to depend on every patient. It's going to depend on, what's the reason that we're discontinuing the medication. So if they're having a significant intolerance that we might want to bring that down the medication that they're on more quickly. And it's certainly going to depend on the specific medication. So if it's an intolerance issue, we're bringing them down quickly. Say they were on Paxil, maybe we're inheriting them and they were on paroxetine and having a lot of difficulty with like in between dose withdrawal, and they're really having a lot of problems with withdrawal symptoms, then we may think about starting them on a longer acting SSRI like fluoxetine, where we're going to maintain some of that serotonergic activity and help kind of smooth those withdrawal symptoms that they're having as we're bringing down the initial medication. If they haven't tried fluoxetine, we may then try to increase that med over time, versus if we're trying to move to a different medication altogether, just using that fluoxetine as a bridge, then tapering them off of that one more slowly. So certainly there's a lot I think that goes into those cross taper protocols, but I think just being really thoughtful about what is the reason we're moving them off it. If they were otherwise tolerating it well and it just wasn't effective, then I think just making judicious down movements and getting, I think, probably within that kind of starting category, like with escitalopram, 5 or 10 milligrams before we start another one, recognizing that we may increase the risk of like a serotonin syndrome if we've got higher doses of two medications going at the same time.
Thank you. Thank you so much. And I just want to say, I loved your comment about, patients who might be not so interested in engaging in therapy and reminding them like that they've built a therapeutic alliance with you as the provider and how they got benefit from that. I thought that was a great point. So thank you for that. And thank you for your really wonderful talk.